Ladies and gentlemen, welcome back after your lunch break, and welcome to the virtual audience as well. I hope you had a good lunch and ready for the next session of lectures. So just a little reminder again about the competition. We do have a few more questions popping up on your screens, and you can venture to answer them, and there'll be prizes lined up for you at the end of the evening as well. So the next lecture is a plenary on hypertension. May I invite the moderators for this plenary as well to come onto the stage. Senior Consultant Cardiologist, Dr. Sepalika Mendes, Consultant Cardiologist, Dr. Izzat Jamaldeen, and Consultant Cardiologist, Miss Sandamali Premaratna, please.
The next lecture is on update on hypertension and by Professor Anushka Patel. She's very well known to us, the Vice Principal Director and Chief Scientist, the George Institute for Global Health, Professor of Medicine, University of New South Wales, Sydney, Cardiologist, Royal Prince Alfred Hospital. She's the Principal Investigator for the TRIUMPH trial with us years ago. And over to you, Anushka.
Thank you very much, and I'd like to really thank the organizers for their kind invitation to present today. I'm very excited to present. It's going to be a little bit of a change of pace from the last presentation, but I hope you'll find it interesting. I'll just share my screen. I hope that's now visible to you. So thank you. So the title I was given for this presentation is an update on hypertension management, but to really set the scene for the focus of at least part of my presentation, I think perhaps a more appropriate title is an update on blood pressure management. To illustrate this point, here is some data estimating the burden of blood pressure related disease globally in 2015, so just a few years ago. And as you can see, at that time, it was estimated there were just under 1 billion people worldwide with systolic blood pressure greater than 140 millimeters of mercury, and approximately 6 million deaths, about 143 million disability-adjusted life years lost were attributable to this, this population. But this is just the tip of the iceberg. A further 10 million deaths and over 200 million DALYs lost in 2015 were attributable to about 3.5 billion people worldwide who have what we would consider non-optimal blood pressure. And that is a systolic blood pressure of between 110 and 140 millimeters of mercury. So collectively, it's been estimated that about 20% of all global deaths are attributable to non-optimal blood pressure. So this is really a massive problem, and it's a growing problem. Each year there's a 2% growth in non-optimal blood pressure in terms of proportions of individuals. So as a consequence, high blood pressure or non-optimal blood pressure, whatever term you choose to use, is the #1 risk factor for any disease globally. It's more than childhood undernutrition, it's more than unsafe sex, it's more than all those traditional risk factors that we think are the important risk factors for global health problems. And this is true not just from a global perspective, but for almost every region of the world. So as you can see, for high-income countries, high middle-income countries, middle-income countries, blood pressure is the #1 risk factor. #2 in low middle-income countries, it's really only the least developed nations of the world where blood pressure is not a leading risk factor for disease, not just cardiovascular disease, any disease. This is really important. So what do we know about the natural history of untreated non-optimal blood pressure? And I think it's important to remind us of that. Certainly in my generation of cardiologists, we don't see a lot of the natural history. This was not the case at the time that this photograph was taken, and some of you might be familiar with this. This is the famous Sick Man of Yalta photograph with the US President Franklin D. Roosevelt in the middle, next to Churchill and Stalin at the Yalta conference at the end of World War II. And he was indeed a very sick individual at this meeting. And he was sick as a consequence of untreated hypertension. And we have, because of his status, we have a very good documented history of the progress of his disease. So he was initially found to have high blood pressure at the age of 54, a blood pressure 162 on 98. That was not treated, even if they had effective treatments at the time. Indeed, it was considered dangerous to treat high blood pressure, which was considered a compensatory mechanism. A few years later, his blood pressure was even higher. He started to get symptoms and was prescribed, amongst other things, taking up smoking. A few years later, his blood pressure much higher, 230 on 140. He now has evidence of end organ damage with heart failure. He has some effective treatment through low salt diet, but still no effective treatments. Then we come to the conference at Yalta, where his blood pressure was recorded as 260 on 150 millimeters of mercury, and he was noted to have frequent lapses. A couple of months later, he suddenly lost consciousness. His blood pressure was recorded at the time of systolic of greater than 300, and he subsequently died, and an autopsy showed the cause of death was cerebral hemorrhage. Now, fortunately, 80 years later, we have available a number of affordable, widely available drugs for blood pressure lowering that have been shown to be effective in a number of large-scale clinical endpoint studies. This is just a small proportion of them. This isn't all the trials. It's probably one of the most studied areas in medicine, let alone cardiovascular medicine. And so we have multiple classes of drugs, and we have multiple agents within each class. So I think it's really important to recognize this and the advances we've made in a relatively short period of time, but also to recognize that there really have not been any major new drugs for blood pressure lowering or treatment of hypertension since the mid to late 1990s. So this presentation is really not going to be around new drugs. Where we've really failed is in the management of hypertension at a global level. So despite having this really quite incredible armamentarium of effective, safe blood pressure lowering drugs, globally we're doing a pretty poor job of achieving adequate blood pressure control. So if you look overall, the bottom line is that amongst all people with hypertension, this is the sort of classical hypertension cascade of care that looks at proportions aware that they have hypertension, proportions on treatment, control among those who are treated, and the proportion controlled overall. Overall, less than 14% of people worldwide with hypertension have adequately controlled blood pressure levels. This is much lower in low and middle income countries, but even in high income countries where resources are not an issue, less than 30% of people with hypertension have adequately controlled blood pressure levels. And this is data from 2016. So rather than focusing this presentation on new treatments or treatments that are used in a very small proportion of individuals, I'm going to focus on innovations in clinical approaches to blood pressure lowering in two areas. First, who we should treat, and second, how we should treat. So what I'd like to do is present you with two case scenarios, two patients, both men, aged 60 years. Patient A has a blood pressure of 140 on 80 millimeters of mercury. Patient B, 160 on 90 millimeters of mercury. But these two patients differ in other characteristics, in tobacco use, in lipid profile, fasting blood glucose, and in anthropometrics. So the question I have is, which of these patients should receive blood pressure lowering drugs? And we'll come back to that. Firstly, I think the epidemiological associations between blood pressure and the risk of cardiovascular events helps us understand and answer the question that I've just posed. On this slide, I've shown the results of two very large collaborative programs that have pooled data from cohort studies. So on the left-hand side of the slide is the prospective studies collaboration, which is essentially cohort studies from mainly Western Europe and North America. And on the right-hand side is the Asia-Pacific cohort studies collaboration, which has participants from cohort studies in mostly East Asia, particularly China, but a number of other Southeast Asian countries, as well as Australia and New Zealand. And in both cases, what this shows is on the horizontal axis is the systolic blood pressure, And then the vertical axis is cardiovascular events, in this case, stroke mortality, but the picture is very similar for coronary heart disease mortality, for example. And the most important observation of these associations is that the associations are continuous and log linear. It is important to emphasize that the vertical scale is a log scale. So what this means is that for any given reduction in systolic blood pressure, regardless of what the initial blood pressure is, you would expect a similar proportionate reduction in relative risk. So if your initial blood pressure is 180 millimeters of mercury, a 10 millimeter of mercury reduction in systolic blood pressure should produce a 30% reduction in stroke mortality, but that should be the same if your initial blood pressure is 130 millimeters of mercury. That's an important observational analysis that has been borne out repeatedly. But these are observational data, so it is important to understand whether the trial data confirms what we see in observational studies. Fortunately, we have quite a lot of data to confirm this. So these are data from the Blood Pressure Lowering Treatment Trialist Collaboration, which is an individual participant data prospective meta-analysis of blood pressure lowering trials that commenced in 2000 and is ongoing. It contains results or data from hundreds of thousands of participants and provides very robust estimates of treatment effects. And what you can see in this slide, for a number of cardiovascular events, so major cardiovascular events, coronary heart disease and stroke, that the proportionate reduction in those events for blood pressure lowering versus control is similar regardless of the initial blood pressure level. So for major cardiovascular events, for example, there is overall a 20% reduction in risk of major cardiovascular events with blood pressure lowering compared to control. But this proportionate reduction is the same if your blood pressure is less than 130 initially or greater than 160 initially. And so this confirms the epidemiological data that I just showed you a minute ago. There is other data that I think is important from the Blood Pressure Lowering Treatment Trialist Collaboration. In this slide, instead of stratifying patients by their initial blood pressure, they're stratified by their baseline future risk of experiencing a cardiovascular disease event. So in this case, a 5-year risk of a cardiovascular disease event, ranging from less than 11% to greater than 21%. And what these data show is that regardless of the initial risk level, the relative risk reduction with blood pressure lowering therapy is the same. It's highly consistent. However, as you'd expect, the absolute risk reduction is greater if the baseline risk is higher. Now you can see there's quite a linear relationship as shown in this slide. So taken together, these data indicate that the risk of experiencing a cardiovascular event rather than the blood pressure level is the most important determinant of the likely benefits accrued from using blood pressure lowering therapy. That's a very important concept. We've known about it for a little while, but it's still not penetrated into clinical practice. So putting this all together, how should we determine clinically who to treat with blood pressure lowering drugs? Well, in the 1950s, even if we had effective treatment, you'd really have to be off the scale in terms of your blood pressure for the guidelines to recommend treatment. You virtually have to be at the point of experiencing a stroke. But gradually, over subsequent decades, we've had a lowering of the threshold at which treatment is recommended, right up until most recently, where in addition to considering the blood pressure level, there's a growing emphasis on the need for and the intensity of blood pressure lowering to be determined by the overall risk of a cardiovascular disease event. So going back to our two patients, I think most of us would not hesitate and we would agree that patient B with a blood pressure of 160/90 should receive blood pressure lowering drugs. I do think possibly many of us, and the evidence bears this out, many of us would not recognize that patient A with a blood pressure of 140/80 is more likely to benefit from an equivalent amount of blood pressure lowering therapy. And of course, this is because patient A has a higher baseline risk 21% 5-year risk compared to patient B, 11% 5-year risk. With similar amounts of treatment, both would expect an equivalent relative risk reduction, about 25% relative risk reduction. But this means the absolute risk reduction for patients similar to patient A will be greater than that you would likely to see for patients similar to patient B. Now, I think it is fair to say that most guidelines around the world have now incorporated this concept of blood pressure lowering therapy decisions being based on a holistic assessment of an individual's risk. As you can see here, this is the 2017 ACC/AHA guidelines, where both the threshold levels for treatment but also the blood pressure goals are in some way determined by some sort of assessment of baseline risk, either using risk prediction tools or clinical history. But it's also fair to say that there's been major changes with the paradigm shift in practice. Most people would still not treat people like patient A that I presented. And we have evidence of that. Even in my country, in Australia, we've done some analyses of hypertension treatment, and many of the patient A type that I've shown, the vast majority would not receive blood pressure lowering therapy, even though the guidelines recommend this. I'd like to now then move on to how should we treat individuals. Now, I think this is how I was taught in medical school to treat hypertension. I'm sure this is still how medical students are being taught. You commence the patient, you try lifestyle, you commence the patient on a first drug at a low dose. You then review them, and if they haven't responded, you slowly increase the dose and then add another drug if that hasn't worked at a low dose, and then increase that dose, and so forth and so forth. The reality is that this is an absolute recipe for undertreatment. And again, we have evidence for that. If you look at the global hypertension cascade for care, amongst those individuals with hypertension who are on treatment, only 37% globally have adequate control. Again, the proportions are lower in low and middle income countries, but even in high income countries with lots of resources, only 50% are adequately controlled. So what's behind this? Well, I think a major driver of this is the sort of sociological phenomenon of therapeutic inertia. So this is something that's very well described, and this is essentially the reluctance of both prescribers but also patients to accept increasing levels of treatment. This is a study in Western Europe that reviewed medical records of about 14,000 visits among about 2,500 patients, and looked at visit by visit when was a treatment change indicated based on the fact that the patient had not achieved targets. And that was indicated during 10,000 of those 13,000 consultations. But no change occurred in 7,500. There's no additional prescription or increase in dose. So in 75% of cases, no change in therapy was made, even though it was indicated. We also, I think, overestimate the effects of uptitration of drug doses and don't recognize that uptitration is not necessarily very effective. These are some data from a systematic review on placebo, looking at the placebo-controlled differences in systolic blood pressure for a range of drugs. There were about 5 or 6 drugs looked at, and compared those placebo-controlled differences at half standard dose, and twice standard dose. And the really important finding here is that across the board, 75% of blood pressure lowering treatment was obtained through the half standard dose. So you don't actually get much more additional benefit from uptitration of dosages once you're at half standard dose. However, the converse is true when you look at adverse events. In this case, for adverse events, for most classes of drug, the standard dose is associated with substantially more adverse events compared to half standard dose. So this is true for thiazide and thiazide-like diuretics, beta blockers, and calcium channel blockers. The only exception seems to be those agents that inhibit the renin-angiotensin system, like ACE inhibitors and ARBs. Taking this evidence together, I think a very reasonable hypothesis is that a strategy of initial or early treatment of hypertension with low-dose combination therapy will achieve better blood pressure control with fewer or equivalent side effects compared to usual care. This hypothesis is based on not eliminating therapeutic inertia, which is really a sociological phenomenon, but essentially trying to bypass it. And this indeed was the hypothesis that we tested in the trial that was mentioned in the introductory comments. In this trial, we randomized participants with hypertension, either newly diagnosed or who are on monotherapy and without adequate control, to a triple pill strategy or to usual care, the triple pill being a fixed dose combination of telmisartan, amlodipine, and chlorthalidone, with the option, this was quite a pragmatic trial, to up-titrate therapy, and primary endpoint was a 6 months, which was blood pressure control. And interestingly, we saw a lot of therapeutic inertia in this trial. So after randomization, particularly in the triple pill arm, there was very little up-titration of therapy, even when it was required. But this was the findings. The triple pill was more effective. 70% achieved target blood pressure at 6 months compared to 55% in usual care. And importantly, this was achieved quickly. So within 6 weeks, this proportion of individuals achieved target, and the mean difference in blood pressure over the course of the follow-up was almost 9 millimeters systolic and 5 millimeters mercury diastolic. Importantly, there was no difference between the arms in adverse events, as shown here in terms of withdrawal of treatment due to adverse events. We didn't find any difference in effectiveness of the triple pill strategy compared to usual care when we stratified the population according to whether this was initial treatment of hypertension or use of triple pill among people who had previously been on monotherapy but were uncontrolled. And I don't have the data on this slide, but we also didn't see any excess in adverse events when the triple pill was used as initial therapy for hypertension. So again, this suggests that the initial use of low-dose combination therapy, in this case triple pill, but this is really added to a growing body of evidence that low-dose combination therapy is an effective and safe approach to really bypass the therapeutic inertia that I spoke about in the management of hypertension. We also looked at cost effectiveness. This was published in Lancet Global Health last year, which showed, you can see the incremental cost effectiveness ratio in the right-hand column. If we just take public sector triple pill pricing at the cost of the sum of the individual drugs, which, because triple pill is not available in the market in Sri Lanka, this is below the cost effectiveness threshold for Sri Lanka. But more importantly, combination pills, fixed dose combination pills of generic components can be manufactured at extremely low cost. So if you can get the polypill price down, this can become really very highly cost effective or indeed cost saving. So as a consequence, not just of TRIUMPH, there's been now a number of studies, and this is really added to that evidence base. Dual fixed dose combination therapy for blood pressure management has been added to the WHO Essential Medicines list for the first time in 2019. And importantly, this is now entering guidelines worldwide. In a number of guidelines, dual fixed dose combinations are recommended for individuals with blood pressure levels above a certain level. The latest International Society of Hypertension guidelines, issued this year, indicate for certain subpopulations, regardless of, even if the blood pressure is above the initial threshold for treatment, that dual FDCs should be considered. So I think this is really going to change our practice moving forward. So I'd like to finish up with really going back to where I started. And that is acknowledging that non-optimal blood pressure is the leading cause of premature death and disability globally. This slide shows the WHO 25 by 25 goals. Is essentially a list of 8 targets, all aimed at reducing premature mortality from non-communicable diseases by 25% in the year 2025 compared to the year 2015. And I think it's very notable that at least 4 of the targets here are directly relevant to blood pressure reduction. I think as clinicians, you know, simply by innovating through focusing on who we treat and how we treat, without really needing to rely on the availability of major new treatments, I believe we can make important contributions to achieving such goals. So thank you very much. And again, I'd like to thank the organizers for their very kind invitation to present today.
Thank you very much, Professor Anushka Patel. It's a very informative and descriptive set of information you have shared with us. I think you have given the broader picture of the global aspect, and we are thanking and we are admiring and appreciating your efforts you have put on this combination pill, the fixed drug combination, especially for countries like us, Sri Lanka. And as this is a plenary, there will be no questions or discussions. And thank you again very much for your active sharing knowledge with us. Thank you.